Good morning. This is a short session on thyroglossal cyst and fistula. And as I keep repeating, it should not be a shortcut to clinical interaction. The images are from my personal collection, and in case I've taken it from my colleagues or my students, then I will give due credit in those images. Let's move on. Now, embryology is of utmost importance in understanding. When we talk of duodenal ulcer, we don't talk about embryology and its importance of the developing duodenum. But there are certain topics which will have a core there, and that is your congenital problems. You need to know their embryology to understand the clinical features, the treatment options, etc. So it develops from the median bud of the pharynx, and the foramen cecum at the base of this tongue is the vestigial remnant of the duct. It's a hollow structure that migrates caudally, goes downwards and processes in close continuity with and sometimes through the developing hyoid cartilage. Your hyoid cartilage is also developing there, and cartilage, as you know, is soft, so the duct is even able to go through it. Then the hyoid becomes ossified, it becomes a bone. Okay, because these diagrams had to come into focus, I put off the video. So, you know, this is the primitive pharynx. Fine. Now you have the branchial arches here. You have a diverticulum from the foramen cecum. Now it's going to go down. As you see, it's going down, and then the hyoid and then the rest of the pharynx will divide into the esophagus and the respiratory system. This diverticulum is going down, and there is a hyoid very close by. Fine. Now as it goes down, then it will go down and form the thyroid gland. Now the thyroid gland is formed from this diverticulum. But the medullary cells or the C cells in the thyroid will migrate from elsewhere. I'm not going to go into that details in this presentation. Now what happens finally? It comes and forms the thyroid gland, and the rest of the gland will get, rest of the duct will get obliterated. Simple. Now, as I told you, obliterated, what exactly happens? The lower part of the gland, the lower part of the duct will form the thyroid gland. The rest of the duct will disappear. Now, is it the end of the story of the duct? No. What happens? It does not obliterate completely. I'm not talking about a cyst. The duct itself may not obliterate completely. What happens? A part of the duct will form a fibrous cord with the hyoid. This is known as levator muscle of the thyroid gland. If it has got some muscle fibers, it's called levator muscle of the thyroid gland. You can see in this diagram here. You can see it here. And intraoperatively, this is what it will look like. Fibrous band. You might have some muscle fibers that is supplied by the thyroid artery and the ventral ramus of C2 and C3. Now, this is particularly for NEET set and NEET super specialty, because I'm now going into the depth to cover NEET and super specialty. They might ask you, what is the exact embryological formation of the levator thyroid glandular levator muscle of the thyroid gland, or the levator glandulae thyroid? And what does it do? It elevates the thyroid. Actually, when the larynx moves up during deglutition, this attachment will also move up. This is particularly important, and that too the nerve supply to that particular, if it is a muscle, if there are muscle fibers, there has to be a nerve supply. So we are going deeper and deeper now. Now, what exactly? You will find columnar cells, they may be stratified. You see the nuclei at different level, and they are ciliated also, but not keratinized. And then you find the thyroid follicles. This is what the cyst will be comprised of. I told you. Okay, now what happens? It goes down below the hyoid bone, and later on it forms the thyroid. Now, somewhere this may not disappear. This may not disappear completely, or it may not disappear, obliterate completely, and you can have collections of cysts along this line. So you can have them just below the tongue, or in the region of the hyoid, or in the region of the thyroid, or just below the thyroid, or sometimes even into the mediastinum also. Any problem that has got a strong embryological basis is likely to migrate here and there. So even though the duct is supposed to stop at the thyroid, it might be going further down. What is a clinical presentation? It clinically presents in children and young patients with an average age at presentation about 6 years. So this is a boy about 6 and this is the girl about 8. Now have a look. This is actually the laryngeal outline, the sternocleidomastoids, the thyroid cartilage. Hyoid is not easy to see, but it can be palpated. Similarly, hyoid, thyroid and cricoid again can be palpated but not easily seen. But your thyroid cartilage can be easily seen, and you have the cyst there. Similarly, there is a cyst here and the thyroid cartilage is here. Now, don't immediately think this is a thyroid swelling. A thin neck individual, when they extend, immediately the thyroid will be more prominent than usual. But what you're worried, what you should focus is these cystic areas and the laryngeal anatomy. As I told you, it happens in young children. 50% of the time it is patients less than 20 years. So 50% of the population will be below 20 years. For example, this is the lady, about 18-year-old girl, and this is a man who's about 22 years old. He has a swelling here. She has one tiny one here. Probably the photographs are not bright enough. Now, can they occur in older individuals? Now, in an image-based exam, they will have an image of a child with a swelling in the neck. Straight away go and write thyroglossal cyst, because you have only a visual image, a 2D image. You don't have any access to palpation there. So the thing will be, you write thyroglossal, you tick thyroglossal cyst. Sometimes 15% can be above 50 years of age. This is a gentleman who has come above 50 years of age. He's got a thyroglossal cyst. And these are the patients. It's been long standing. It's been there. He may not have noticed it, or he might have decided it's not the right time or appropriate time he found to come to you. They are likely to have squamous type of thyroglossal duct carcinoma. Because the lining is squamous cell, they will actually go into a squamous cell carcinoma. This man doesn't have, but I'm telling you that older age, they are likely to present like this. So it's a soft midline swelling which moves on protrusion of the tongue. So you have cysts all along. You protrude the tongue. You protrude the tongue. Naturally, the cysts here will move up. This is a small video. And one thing, particularly when you ask them to swallow for a thyroid swelling, that is different. They do it without much ado. But when you ask them to protrude the tongue, it needs a lot of priming to the patient. Don't be harsh and say, put your tongue out. They will do it with such a jerk that you get, upset. No need. Give them enough time. Tell them to open the mouth and to remain like that. To remain opening the mouth, ask them to put the tongue out very slowly. No jerky movements. When there are jerky movements, you're unlikely to appreciate the findings. And then because you did not appreciate the findings, you ask them to do second time. These were not activities that a layperson is doing every day in their house. It's a new activity. It might appear simple to you, but it's a new activity for the patient, especially they come to a crowded OPD, they are fully anxious, and then you ask them to do an activity which apparently appears very simple to you. It is simple to you, apparently appears very simple to you, to the other patients, and to the patient herself, but not able to do it. So ask them to do it slowly and give enough time. அப்படியே வச்சுக்கோ. வாயை தர, மெதுவாக நாக்க வெளியில் இழு, நல்லா இடு, நாக்க வெளியில் தள்ளு, உள்ள வை, நாக்க வெளியில் தள்ளு,
You can see the moving.
நாக்க வெளியில் தள்ளு, உள்ள வை, அதே மாதிரி சைட்லேருந்து எடுத்துடுறேம்மா. நாக்க வெளியில் தள்ளுடா, உள்ள வை, நாக்க வெளியில் தள்ளு, உள்ள வை, ஒரு நிமிஷம் மேலே போ. வாயை தர, நாக்க நைஸாக எடுத்துட்டு வா வெளியில், உள்ளே எடுத்துகிட்டு போ, நாக்க வெளியில் தள்ளு, உள்ளே எடுத்துகிட்டு போ. Now what happens? How do they? Yeah, one, they come for help, or number two, they will straight away come with an infected cyst. And you can see the skin reddening here. Skin is red and shiny. Now this will rupture, or you can even do an IND. It's an abscess stage, it has to be let out. So once that happens, then they will be left to the fistula. That is a thyroglossal fistula. Nobody is born with a thyroglossal fistula. It's always a cyst which ruptures, fine? And then it becomes a thyroglossal fistula. Now this thyroglossal fistula will also move with protrusion of the tongue. I don't have the video, but this is after she is protruding the tongue and we have taken a still picture. So as I told you, there are many, the cysts can form all along the course. So that can be just under the tongue, somewhere here, near the hyoid bone. This is your hyoid and this is your thyroid. But if you really look at it, most of your cysts will be happening in this hyoid and thyroid areas. It can be suprahyoid, it can be infrahyoid, it can be in the thyroid, and sometimes it can be below the thyroid where it is called suprasternal. Let's have a look. You can see here, you cannot palpate you cannot see the hyoid bone easily. So this may be sitting on the hyoid, or it may be even above the hyoid. Then you have the one just below the hyoid. The very fact it is sitting above the thyroid, it is below the hyoid. So it is subhyoid. And then you have one sitting bang over both parts of the thyroid as well as the hyoid. And you have one in the suprasternal notch. Sometimes it can even extend into the mediastinum. You can have cysts going into the superior mediastinum also. So this is easy to understand. You have the CT. These are the lingual cysts. Now what happens? The thyrohyoid area gets the maximum cysts. That area will have the maximum cyst, which is about. So the most common location of a thyroglossal cyst is in the thyrohyoid area. Mediastinum, of course, is rare. As I told you, the most common is the thyrohyoid area where you will get lot of these cysts. See here. What investigations would you do? Clinical examination of the cyst is sufficient in children if surgery had not been done earlier. I'll come to it later. Now, apart from that, you need to palpate the normal thyroid. It's very easy in a reasonably weighted individual. You can palpate the normal thyroid. So you need not think this cyst is an ectopic thyroid. You can go ahead and remove it. Ultrasound may be needed to localize your normal thyroid in very obese patients. Very obese, you cannot palpate the thyroid. There is too much of subcutaneous fat. So in that case, you need the ultrasound. Elderly, when they come with the features of thyroglossal cyst, please do an ultrasound because you want to look for malignancy in the thyroglossal cyst. Then it will not be just simple excision. Your treatment plan will change. CT and MRI you will do in adults when you suspect malignancy, or recurrence for beta anatomy. Suppose in children you have operated, there is a recurrence, then you again do a CT and MRI for them also. That's why if surgery not done earlier, clinical examination is sufficient provided you get the thyroid by palpation or by ultrasound. So this is an ultrasound. These are the lobes of the thyroid and you have the cyst. So you found out they are normal lobes, nothing wrong there. Thyroid is very much there and normal lobes, and you have a cyst here. It will appear as an anechoic area with the post-acoustic shadow. See, this is the post-acoustic shadowing. Posterior acoustic enhancement. Okay. This is your CT. Look at your hyoid bone. This is your hyoid bone. And this is your large cyst here. Now this boy whom we thought is likely to be a thyroglossal cyst, it turned out to be a submental node. So the DD is up there. Your submental node will also move with deglutition of the tongue. But then I also put this diagram to see surface anatomy of the larynx. He is a thin boy and that too a boy. So you can see the thyroid cartilage and all that very well. Don't mistake this to be a swelling. This is normal larynx. You'll be happy you managed to get to see the normal larynx also. This is your swelling which turned out to be a submental node. Either on the node you picked up on an ultrasound or you did an FNAC and you found out it's a node. It's also moving, see? So you got it. You can see the lot of background. Other patients are telling him what to do. This is how you'll be able to handle clinical findings in your busy OPD. Okay, this is another patient who had a swelling here and it turned out to be a submental lipoma. There is skin there. Likely, there is subcutaneous tissue there. You're likely to get problems from those tissues, not necessarily your thyroglossal cyst. Now, because it was quite huge, I am also looking at the floor of the mouth to make sure that this is not a ranula. If it's a plunging ranula, you need to look at the floor of the mouth. This is just a collateral information by the side. Now, this is that same gentleman about more than 50 years who had come with a thyroglossal cyst. What I wanted to tell was, you see this neck is the normal usual position. You're able to see the cyst. But once you give anesthesia, you'll be able to hyperextend. You cannot hyperextend this neck. As I told you, they are quite obese. That is why I said sometimes you need ultrasound to pick up the normal thyroid in these people. Fine. And then number two, why I put this photo was, when you hyperextend, you can see the cyst better. And you cannot hyperextend in the OPD or in the wards. You can only hyperextend when he is under anesthesia. And this position, hyperextension, is basically to do the surgery, not to define the swelling and do a clinical examination. But by the by, I told you that when you hyperextend, you can see the swelling better. So now let's have a look. This is a same child under anesthesia. You can see this is the tracing of the hyoid bone. You cannot see the hyoid bone, but you can palpate, and this is your cyst. It's a subhyoid cyst below the hyoid. Again, this is another chap. You can palpate the hyoid bone, and this is the thyroid cartilage, and your cyst is sitting over the thyroid hyoid area. Same small child, you can see it's a suprasternal area. The cyst is in the suprasternal area. Where would you put the incision? It is not a thyroid incision. You would put the incision over the summit of the, let us use pen, highlighter or pen. See, you would put an incision over the summit of the cyst. If the cyst was here, you would put it here. If the cyst was lower down, you will put it lower down. So you will put an incision over the summit of the cyst. If the cyst was in the suprasternal, accordingly you will put the incision. Now, excision of the cyst. Let me explain. Cyst was somewhere here. When you excise, you need to excise the central portion of the hyoid. I am not telling the whole hyoid bone, but the central portion of the hyoid, about 1 centimeter total width. You have to excise that. That is known as Sistrunk's operation. Now you can make out incision has been made, dissection has been done, the cyst is there, it is being held, and then this is the tract nicely dissected and brought up to the hyoid, and this is the central portion of the hyoid you have exposed. You need to expose the central portion of the hyoid and excise the central portion of the hyoid along with the attached fibrous cord and the cyst. This is known as Sistrunk's operation. Again, in your NEET set, they might ask you the classical step in Sistrunk operation is incision, the excision of the central portion of the hyoid. Very tricky. They will write excision of the hyoid. Then you will write that nobody will excise the whole hyoid. You can see here, again, this is zoom view. The cyst is there. This is that has been nicely dissected and it's going up to the hyoid. Even if it's, and you need to excise this part of the hyoid. You can see it in the resected specimen. Again, central portion of this is a fistula we have dissected, and this is the central portion of the hyoid exposed well to excise. So this is taken from the net. You remove the cyst and you remove the central portion of the hyoid, not the whole hyoid, central portion of the hyoid, and this is what you will find. This is the central portion of the hyoid and this is your cyst. This is one from my LinkedIn colleague. He had sent this photograph, so I watermarked it. You have the cyst and this is a very small child, so the hyoid is not going to be huge. It's a small, almost it will be a cartilage. So the incision will be made on the summit of the swelling. So that's it for today. Thank you all so much and please do subscribe. I'll be regularly posting videos. And if there are any specific questions to be asked or to be explained, please put it in the comment box and I'll be too happy to answer it for you. Thank you again so much and take care.